Yeah. Hello, everyone. I welcome you today to the session of Prolonged Neonatal Jaundice brought to you by Apollo Cradle and Children's Hospital. To speak on this topic today, I would like to welcome Dr. Imran here. He is an internal pediatric consultant associated with Apollo Brookfield Center in Bangalore. He has done his MBBS, MD into pediatricians and DNB into neonatology. He's a very renowned pediatrician and neonatologist with Bangalore Center. We welcome you, doctor, to this session, and we are looking forward to know more about what is to be done in the prolonged neonatal jaundice and what things to avoid. So, sir, session is all over to you. I will, as soon as I get some questions, I will post it on the chat for you to answer. All yours, sir. I'll be there on the background. Thank you.
Yeah. Thank you, ma'am. Good morning to you all. My name is Dr. Imran, neonatologist, cum pediatrician at Apollo Cradle Hospital, Brookfield. Today, I am going to talk about a very important topic, that is the prolonged neonatal jaundice. Neonatal jaundice is a common symptom encountered in neonates from day-to-day life. So we are commonly seeing majority of babies born with presenting with symptoms of neonatal jaundice, yellowish discoloration of the skin, as well as the sclera. So as we know that around 70 to 80% of the babies develop neonatal jaundice, but few of them require some additional therapy like phototherapy that helps in decreasing the level of jaundice. As you know that the majority of the cases of the neonates, they present with physiological jaundice that will resolve usually by 2 weeks of age. The onset of jaundice usually occurs by 2 to 3 days, which gradually peaks by 3 to 5 days in preterm babies and 5 to 7 days in term babies, and gradually tapers down and normalizes by 2 weeks of age. There is no clear-cut definition as per the literature for the prolonged neonatal jaundice. But as per the statistics, what we can label it as a jaundice persisting beyond 2 weeks of life in term neonates or beyond 3 weeks of life in preterm neonates as a prolonged neonatal jaundice. It usually occurs in 15% of the newborn babies. So the vast majority of these children have a benign unconjugated neonatal jaundice. There are two types of jaundice, that is the unconjugated jaundice versus the conjugated jaundice, that is mostly related to the surgical causes. Majority of the children with prolonged neonatal jaundice belong to a unconjugated group. But there is also a certain part, that is around 1 in 2,500 births, they present with surgical jaundice or cholestatic liver jaundice. The early identification of this cholestatic jaundice or conjugated hyperbilirubinemia is necessary because early identification of these babies helps in improving the long-term outcome of the babies, especially in surgical cases like extrahepatic biliary atresia, where if we recognize and treat it before 30 to 60 days of life, the outcomes improve drastically. So the difficulty which we face commonly is whether it is a serious conjugated hyperbilirubinemia type or surgical type versus the benign unconjugated type, because they form the majority of the cases. Because in both the conditions, the babies look clinically well during the initial part of the symptoms. Okay, so early identification of these surgical cases is necessary. So how you can identify whether it is a benign unconjugated type versus a little bit serious type liver disease or a conjugated hyperbilirubinemia type? What we need to identify is the diaper staining along with the color of the stools. Because in conjugated type, the baby is present with little bit dark colored urine along with pale colored stools. So dark colored urine you may identify as a diaper staining in these babies. They may point towards a conjugated type of neonatal jaundice. And in other cases where the benign type, the color of the baby is present usually with excessive weight loss or breast milk jaundice. So coming to the various etiologies of the prolonged neonatal jaundice, what we commonly seen is the benign type. So they include inadequacy of breastfeeding, or they present with excessive weight loss, and they predominantly present with unconjugated type of neonatal jaundice. There is another entity which is known as breast milk jaundice, exclusively seen in breastfeed babies. And there are other conditions like hemolytic disorders like RH, ABO, G6PD deficiency, or any other conditions like hereditary spherocytosis. They also may present with prolonged neonatal jaundice. There are other rare categories which I have told you earlier, like surgical causes, extrahepatic biliary atresia, or there are other conditions where the baby is present with sepal hematoma which causes occult bleeding that may result in prolonged neonatal jaundice. On newborn screening, we may detect some other rare conditions like hypothyroidism, which if we intervene early, the outcome of the babies is better. Other conditions like galactosemia, where the baby is usually present with low glucose levels, these may also cause prolonged neonatal jaundice. Other conditions, rare syndromic features like Gilbert syndrome, Klinger-Nadja syndrome. There are other conditions which may also present with prolonged neonatal jaundice. So, as I have told earlier, how to evaluate whether it is a benign type versus it is a surgical type. Benign type usually present with unconjugated type of neonatal jaundice. The surgical cause is present with predominantly conjugated type of neonatal jaundice. Clinically, the baby is present with a dark colored urine and pale colored stools in case of conjugated type of neonatal jaundice. They usually have symptoms suggestive of some liver disease, like deficiency of fat soluble vitamins like vitamin D, vitamin K, etc. Vitamin K deficiency in these newborn babies may present in the form of bruising, bleeding tendencies, etc. Some babies, we have also seen babies coming with hypocalcemia and neonatal jaundice. Hypocalcemia usually occurs because of the vitamin D deficiency in these babies. That may be a secondary part of a liver disease and ultimately due to conjugated hyperbilirubinemia. Some babies may also present with seizures secondary to neonatal jaundice or hyperbilirubinemia as well. Some babies present with poor feeding, lethargy, symptoms suggestive of sepsis that also need to be taken into an account. So these sensitive markers like dark colored urine or diaper staining along with the pale colored stools is important to identify, and recognizing early will help in improving the management of the baby. So whenever such babies come to the OPD, there need to be certain pointers in the history we need to identify, like whether the parental history of consanguinity or a close relation marriage is there or not, or any babies requiring jaundice phototherapy phototherapy for neonatal jaundice in the sibling or in the family, any history of recurrent abortions, any history of transfusions in the family. These are the various pointers in the family which we need to pick up. Along with that, there are from the antenatal scans itself, there will be certain clues regarding the structural abnormalities that may help in identifying few syndromic diseases. And whenever mother suffers with any excessive cholestasis, they may also present with rare disorders that is responsible for prolonged neonatal jaundice. And there are also certain conditions known as torch infections in a mother that may also cause infection in a baby, ultimately resulting in neonatal jaundice. So coming to the infant history or baby history, what we need to closely monitor is the how preterm is the baby. Because whenever the baby is a little bit preterm, less than 32 weeks, the baby is dependent on parental nutrition because the baby won't be able to digest the food properly or the milk properly. In this scenario, the baby will be given total parental nutrition, that is the protein, IV proteins and fats. Sometimes they may also contribute to the cholestasis or neonatal jaundice subsequently. Other history like neonatal infections, urinary infections, what is the source of nutrition? As I have told earlier, there is an entity known as breast milk jaundice, which is exclusively seen in breast milk, exclusively breastfeed babies. And also we have to also identify whether some certain features of sepsis, that is the poor feeding, the baby is lethargic, excessively sleeping, not able to get up from sleep. These are the other pointers that you need to pick up to rule out whether it is because of infections or it is because of any other metabolic disorders, which we need to pick up early to treat appropriately. And other part, like I have already told you about the clinical symptoms like diaper staining is there or not, or pale colored stools is there or not, that may also give us a clue whether it is what type of jaundice it is. So coming to the head to top examination, there are certain conditions like Watson-Elgin syndrome, where the baby present with little bit dysmorphic faces, prominent forehead. They also present with cardiac abnormalities that may help in picking up subtle conditions. As I have told you earlier, some fat-soluble vitamins like vitamin A, D, E, K, they may also present with various clinical manifestations like vitamin K disorders present with bleeding and bruising in a baby. Vitamin D deficiency may present with hypocalcemia, subsequently seizures. Vitamin E deficiency may present with little bit hemolytic anemia features. The baby may present with little bit dull and inactive baby or hypotonia in such conditions. Some babies may also present with little bit abdominal mass, like in conditions of choledochal cyst or any tumors like neuroblastoma. They may also present with prolonged neonatal jaundice. So as I have told you, majority of these babies present with unconjugated type of neonatal jaundice. But there is also a subtle category like conjugate hyperbilirubinemia. How you will identify it? So whenever the baby is having prolonged neonatal jaundice, the first thing what you need to do is to evaluate what type of jaundice is there, whether it is a conjugated type or unconjugated type. Conjugated hyperbilirubinemia is labeled as when the conjugated level is more than 20% of the total bilirubin, we label it as conjugated hyperbilirubinemia. So what are the various common causes of these conjugated hyperbilirubinemia? They include structural causes like extrahepatic biliary atresia, choledochal cysts, they present with little bit abdominal mass, Watson-Elgin syndrome, which may present with dysmorphic faces, neonatal sclerosing cholangitis. These are various structural abnormalities that we need to pick up whenever we suspect conjugate hyperbilirubinemia. There are other conditions like whenever mother is suffering with torch infections like toxoplasma, cytomegalovirus infections, herpes infections, adenovirus, it may also pass on to the baby, ultimately affecting the liver, which may contribute to this cholestatic liver jaundice. Sometimes babies with prolonged neonatal jaundice, we may also need to evaluate for occult urinary tract infections. So as I have told earlier, the clinical manifestations like dull, lethargy, poor feeding mostly mimic the sepsis or infections, but there is also another category which may present with prolonged neonatal jaundice along with features mimicking sepsis, that is the metabolic disorders like galactosemia. These babies, they usually present with features suggestive of infection, that is dull, lethargy, along with seizures because of hypoglycemia, which we need to pick up. There are other metabolic disorders like alpha-1 antitrypsin deficiency or tyrosinemias or any glycogen storage disorders. They also affect the liver and cause prolonged neonatal jaundice. Other conditions like genetic disorders like trisomy 18, 13 may also rarely present with neonatal jaundice. Other tumors like neuroblastoma, hepatoblastoma, but they are very rare in instance. But what we have to ultimately identify is whether it is a conjugated type versus unconjugated type. There is also endocrinal disorders like hypothyroidism or hypopituitarism that may present with this neonatal jaundice. So whenever a baby with a prolonged neonatal jaundice comes to an OPD, what we have to rule out is what is the type of jaundice first, and then the certain conditions that will mandate immediate treatment like infection, metabolic disorders like galactosemia, hypothyroidism, endocrine disorders, any liver hepatitis, or any other surgical condition like extrahepatic biliary atresia. Whenever they are identified, they need to be acted upon immediately. So what are the various pointers from the history which we need to identify for various certain disorders which are common in this age group? So coming to the endocrinal disorders like congenital hypothyroidism, the mother has a history of hypothyroidism, baby presents with prolonged neonatal jaundice, may have little bit hypotonia, or the baby may be lethargic, poor feeding. Some babies pass stools for 5 to 7 days because they face features of constipation. Some babies may also have other conditions like little bit hypertonic. Breast milk jaundice usually seen from the end of first to 1 to 2 weeks and may even last up till 2 to 3 months of age. But this jaundice is rarely requires any treatment. In case some babies of suffering with breast milk jaundice may require phototherapy based on the level of bilirubin. Apart from these, there are other rare syndromic features. This is a diagnosis of exclusion, like whenever there is a history of consanguinity in the parents, or requiring need of phototherapy frequently, these babies may have features of Crignon-Najjar and Gilbert syndrome. Crignon-Najjar is again divided into type 1 and type 2. Type 1 is the most severe form. It may have jaundice as high as 30 milligram per deciliter that may require intensive phototherapy or even in some cases exchange transfusion as well. Apart from this syndrome, there are other entities like hemolytic anemias, as I told earlier, like G6PD deficiency or hereditary spirocytosis. For this, peripheral smear examination is necessary. Peripheral smear may show around 20% of the spirocytes in case of hereditary spirocytosis, may show some Heinz bodies in case of G6PD deficiency. So this the crux of it is first we have to differentiate whether it is a prolonged unconjugated type versus conjugated type. In case of conjugated type, that we need to first identify with the ultrasound abdomen what is the type of what is the reason causing conjugated hyperbilirubinemia. So whenever we identify this, it is a conjugated type of jaundice, we have to also evaluate for other conditions like sweat chloride test, alpha-1 antitrypsin levels for subsequent cystic fibrosis and any other deficiency. Ultrasound abdomen helps in, it is not a confirmatory test, but it is just a screening test to identify whether any structural abnormality is present or not. It may help in differentiating whether it is a cholelitical cyst, or in case of some babies may have a small contracted gallbladder in the ultrasound abdomen, which may be a pointer towards extrahepatic biliary atresia. And in some cases, it may also help in picking sclerosing cholangitis or Watts-Algil syndrome. Chest X-ray can be done in certain scenario because vertebral anomalies are also common in this age group. So the presence of jaundice in these in the formula-fed babies beyond 2 weeks of age or beyond 3 weeks of age in a case of a breastfed infant need to be evaluated. So conjugated bilirubinemia, more than 20% of the total bilirubin is considered pathological. We may also have to check for the palpate the abdomen for any hepatosplenomegaly in case of hemolytic jaundice. Thank you, one and all. I would be happy to answer any questions if needed. Yeah, I could see one of the question like, why is the jaundice common in newborn babies? That's a good question because whenever a baby is born, the baby is born with a little bit more RBCs compared to the adults. Jaundice is nothing but hyperbilirubinemia, that is the serum bilirubin levels more than a significant amount. The bilirubin is a byproduct of the red blood cells. So whenever a baby is born, because of the more number of red blood cells, they have a tendency to break down into more number of bilirubin levels. So as a result, the jaundice is common. What causes the prolonged jaundice? See, as I have told earlier, it is a vast entity, but only 15% of the babies may have this kind of prolonged jaundice. Like among this, what is important is whether it is surgical type of jaundice or whether it is an unconjugated type of neonatal jaundice. That is need to be identified. There are various conditions that common conditions I have discussed earlier, like urine infections or sepsis is the first thing, then the metabolic disorders, then the breast milk jaundice, then the rare conditions like extrahepatic biliary atresia. These are the various causes of prolonged neonatal jaundice. What happens if the baby has jaundice for a long time? Yeah, so jaundice ultimately results in more increased level of hyperbilirubinemia that will ultimately cross the blood-brain barrier and may affect the brain. Why it is? Because whenever it affects the brain, the long-term outcome, that is the activity and the normal development of the baby may be impaired. So we have to identify what is the cause of the jaundice first and then act accordingly. Can breastfeeding affect jaundice? Yeah, definitely. Breastfeeding may also affect the jaundice because the breastfeeding, they contain certain enzymes that will cause increased level of serum bilirubin levels. When should I get my baby checked after leaving the hospital? See, the majority of the babies have a jaundice level that will have an onset by 2 to 3 days of life. They gradually increase by 5 to 7 days and ultimately come down by 2 weeks of age in majority of almost 80 to 90% of the babies. Whenever after discharge, the baby has a poor feeding, or the baby is not able to get up from sleep, or the baby is looking excessively yellow, what you need to do is, first thing, you have to bring the baby to the OPD. We usually discharge the babies by second to third day of life, and we ask them to follow up by around 6 to 7 days to identify this jaundice. Jaundice level also may increase. So in such scenario, we need to frequently follow basing on the factors associated with it. So what food should be avoided during this period? See, this type of jaundice is entirely different from the adult type jaundice. There is no guidelines to restrict these kind of foods for the jaundice and all. So there is for the maternal diet, it should be routine as advised by your obstetrician. There is no need to avoid any food products. When to worry about discharging and what to do after knowing this? Yeah. See, majority of times after discharge, what we usually ask them to come for follow-up after 3 to 4 days to identify how the baby is feeding, how is the urine output of the baby, and whether the baby is gaining weight normally or not. Because these are necessary to identify and picking up certain signs of any jaundice. So yeah, thanks a lot for all the questions. Yeah. So what we need to identify is, the first and foremost is, whenever a baby presenting beyond 2 weeks of life with clinical symptoms suggestive of jaundice, first thing is to differentiate whether it is a conjugated versus unconjugated. Conjugated, they occur in minority of the cases, but they play a crucial role in identifying and treatment early, because early treatment will be having better outcomes, especially in conditions like extrahepatic biliary atresia. Clinically, whether you can identify this, it is, yes, definitely we can identify clinically basing on the what is the color of the urine and what is the color of the stools. That may help in picking up between these two. And whenever we notice this kind of conjugated hyperbilirubinemia, we have to intervene with ultrasound abdomen and uh, approach subsequently basing on what is the condition of the baby and what is the cause responsible for this conjugated jaundice, whether it is because of infection or metabolic disorder or any structural causes are there, like that. And whenever we identify a conjugated jaundice, then subsequently we have to advance the level of management like HIDA scan or intrahepatic cholangiogram. These are the various investigations that need to be considered. Thank you, Vanana. Yeah.
Thank you, sir. Thank you so much for the wonderful session. I will end the broadcast. It was interesting knowing from you. Thank you again.
Yeah. Thank you.